Hi everyone, welcome back to the Thinking Mind podcast this week. This week it's Anya and we're here today with Professor Nav Kapur. Professor Kapur is an academic psychiatrist. He's Professor of Psychiatry and Population Health and an honorary consultant psychiatrist with Mersey NHS Foundation Trust. He leads the suicide work programme of the National Confidential Inquiry into Suicide and Safety in Mental Health. He's won awards for the quality of his research work and his ability to link this with work with policymakers, clinical services and advisory bodies in order to get his research into practice and making a difference to people's lives. This is a conversation about suicide and self-harm, and as such will cover topics that people may find difficult to hear about and to talk about. My hope with this episode and other ones that are in the pipeline like it is that by offering more information, more facts, and also more nuanced conversations about suicide and self-harm, we can help break down some of the stigma around it and some of the difficulties that people have in opening up about thoughts of suicide that they may be having themselves, and make it easier for people around them to speak to them about those. This is the Thinking Mind podcast. Here you can access in-depth conversations about psychiatry, psychotherapy, and philosophy. These conversations are made to be accessible and enjoyable to all. Thanks so much for listening. Welcome. Hello. Thank you so much for joining us today.
I'm really delighted to be here, and thanks for inviting me.
It's an absolute pleasure. So, Professor Kapur, I'm hoping that today we can talk about your research into self-harm and suicide and the work that you do at the university, but also linking this with clinical practice, your work with policymakers, your work in changing practice to try and make people's lives better. When we kick off, I always like to get a sense of how people came to get interested in what they work in. And so I wonder if you'd be open to sharing with us how you came to work in this field, what got you interested in psychiatry more generally.
Absolutely, Anya. I'm asked that a lot, actually. The psychiatry bit's pretty kind of straightforward and easy and a bit kind of cliched, really. So as a medical student, just thinking about what I wanted to do later on, it certainly wasn't going to be kind of orthopedic surgery. It certainly wasn't going to be a kind of medical hospital-based specialty. But the two things that really stood out to me were primary care, general practice, and psychiatry, because they were the specialties where you could use your interpersonal skills to really make a difference to people's lives. And so I kind of toyed with the choice and wondered about the choice for a little while, but then decided psychiatry was really for me, because it was an opportunity to study one thing in more depth, and it was also kind of fascinating. I remember as a fourth year medical student being on a liaison psychiatry wards at Leeds General Infirmary, and just being exposed to things I'd never been exposed to before, thinking about illness in a way, in a holistic way that I'd never thought of before. So I was kind of hooked on psychiatry, applied straight after. In those days, there were no foundation jobs in those days, Anya. It was house jobs. So straight after house jobs into psychiatry training. Didn't get in first time I applied, and tried again, and then got into psychiatry training. But then the path to academia is a bit more kind of murky, actually. So I remember vividly at a journal club, this new thing called evidence-based medicine was mentioned, and I thought I was terribly skeptical of it. And I thought it's never going to catch on, this evidence-based medicine, because I thought it was essentially academics engaging in a kind of self-serving kind of exercise. I couldn't see how that was going to make a difference to clinical practice. I'm pleased to say in the interim I've kind of slightly changed my mind, although from time to time I come full circle. And what really I think changed my mind was just during clinical training, the opportunity for a research job came up. As I sometimes do, 12-month research job focused on self-harm, actually. So an area that I'm still very much involved in. So I can't remember, third year training or something, doing a 1 year research job. And I was second choice for that job. I subsequently found out, so that's been a kind of recurring theme throughout my career. But I got the job in the end, and I just found I took to it. I just loved it. I loved being able to organise my own time. I loved, being able to look at a problem from several different angles and think about how to solve it. And a lot of my mates in the interim have said, "You're really lucky now. You're really lucky to be an academic psychiatrist because, you get to think for a living." And that's something that really, really sticks with me. And so once I'd done that 12-month research job, I thought, this is definitely something I'd like to do. In those days, as part of psychiatric training, it was pretty easy to do a master's. So I did a master's as well, focused on the health of junior doctors while they were working shifts. And then, I was sure I wanted to take an academic post. I took a lecturer post. And just on a whim moved over to Manchester because I was in Leeds. I moved over to Manchester on a kind of bit of a whim, and it was good, and I've not looked back. And rather embarrassingly, I've been in Manchester since 1997, which is an awfully long time ago. But yeah, no. So that's a rambling history of where I've got to where I've got.
So you started off researching self-harm, and how did that interest develop for you? What kept you interested in researching self-harm and now suicide as well?
Well, that's really interesting because I think, for people listening, especially kind of trainees thinking about research areas, there was a bit of chopping and changing really. So self-harm, the original project, it was the project where there was a 12-month research placement. So that was kind of serendipity, but it was really interesting. And things like self-harm and suicide are really interesting because they're kind of multifactorial. It's just not just mental health causes. It appeals to the kind of public health bit of me. So, all the kind of societal causes. And it's that, combination which psychiatry has as well of, something that's intensely personal, intensely individual, but in a societal context. So, I mean, I found that really interesting. But in fact, what I then did was move away from suicide and self-harm kind of research for a while, and as I said, my master's was really on the mental health of doctors, and then my MD, actually I was much more into illness behavior. So it's thinking about why people might visit their general practitioners a lot, what might be the role of early childhood factors, particularly aversive experiences or early exposure to illness behavior in later life. So I developed my, I developed my interest in kind of epidemiology and epidemiological methods. So, I'm a kind of statistics and kind of data guy in terms of my kind of research, and that's where I developed that. But it was a move away from self-harm and suicide. But then again, it was kind of serendipity that made me go back. There was a Lewis Appleby, who many of your listeners will know, was the National Director for Mental Health, and was doing all his government stuff and needed someone to run his research unit, which was primarily focused on suicide. And people said, "Oh, you might want to apply for that job. It's a senior lecturer job. You come into the end of your training." I was going, "Nah, I don't fancy it." And that's partly because Lewis and I had an entertaining skirmish in the pages of the psychiatric bulletin, which is called something different now, isn't it? It's I can't. Is it called the Psychiatrist still? I can't remember. Anyway.
Yeah.
So we had a bit of a skirmish, and I was a bit wary of him. But then I went to see him, and we hit it off. And again, it was the job that was available. It was suicide and self-harm, and that was fantastic for me because it was an opportunity to really kind of develop my skills and, develop kind of outputs and research lots of different things in a unit that was already established. So that was fantastic for me, really. But it was kind of more luck that I came back into suicide and self-harm rather than by design.
And I think it's something that so many people describe with their career, that it often sort of happens that there's a degree of motivation that you put into it, but then in terms of, and you may have an idea of what you like, but then things happen, and if you follow them, more things happen.
Absolutely, absolutely. And sometimes trainees listening, you'd be thinking, I've got to map out my career. And actually, I mean, there are a few people like that. I know a few of my colleagues have mapped out their career and kind of hit every target. Many more of us, though, it's a bit like me. It's serendipity, luck, stuff that happens. So yeah, I think not planning things too carefully is a really good move.
And let's think about the work that you do now in a bit more depth, because you're from the way you've described it, of things happening serendipitously. You are now leading things like NICE guidelines into self-harm, suicide, also leading, I believe, the National Confidential Inquiry into suicide. And so I wonder if you could start by telling us a bit about the scale of the problem. I mean, many people listening have probably been touched. It's somewhere in their life, by someone dying by suicide or by someone struggling with self-harm. How big an issue is it at a societal level?
Yeah, I mean, it's a huge issue, and it's not just a mental health issue, it's a kind of societal issue. So if we're thinking in terms of the UK, over 5,000 deaths per year in England and Wales annually. Globally, it's a huge global problem. We're talking about, 700 to 800,000 deaths per year. If you take into account things like underreporting, it's probably 1 million deaths per year worldwide. So it's a huge issue in England and Wales, but it's also, a massive issue globally. And obviously, it's the people who tragically lose their lives to suicide, but it's also the people who are left behind. So thinking about the impact of suicide bereavement, that's important. Thinking about, sometimes when if we switch to a kind of slightly researchy type angle, thinking about suicide for a second, there's also this idea of, burden and the disproportionate burden on young people as well. So one of the things we sometimes talk about in terms of research and public health is potential years of life loss. So, it is unfortunately, young people do take their lives. It's one of the commonest causes of death in young people in most Western societies. And if we think about, the burden in terms of years of life lost potential, it's obviously a major factor there. I mean, that's suicide. And then we come to self-harm. Now, many of your listeners will know, but many might not. When I'm talking about self-harm, I'm taking quite a broad view of it. So sometimes people, when I talk about self-harm, think that I might be referring to, self-cutting, perhaps particularly in young people. In fact, the UK conceptualization of self-harm is a broader one. So it's intentional self-injury by any method. So in hospitals, mostly where I work, it's largely self-poisoning. So people having taken overdoses, mostly of medication. But in the community, yes, it's things like self-cutting and self-injury. So quite a broad conceptualization of self-harm. And again, a really important health problem, but a really important public health problem as well. So if we're thinking just in terms of the people that present to services, that's about 200,000 people per year presenting to hospitals. And it's one of the commonest reasons for medical admission to self-harm in this country. And again, many people don't realise that. That's only the people who present to services. And we often talk about the iceberg model of suicidal behaviour, the iceberg model of self-harm, because many people who hurt themselves don't come to medical attention, don't see their GPs, or, for some people it's hidden. So you've got 200,000 people per year who are, if you like, above the waterline, if we're thinking about the iceberg analogy, but you've got all these people who are underneath the waterline. And it's a big problem in its own right. But the other reason, sometimes people say, oh, why do you study suicide and self-harm? Surely they're different. And of course they are different in some ways, but they're also linked. So probably over half of people who die by suicide have had a history of self-harm. And in the year after, someone presents to the emergency department in, South London, or the emergency department in Manchester with self-harm, they're at about, 50 to 100 times greater risk of suicide than the general population. So these things aren't the same, but they're linked, and both of them, I think, are both societal problems as well as specific health problems. People might sometimes say, well, suicide's mostly a public health problem. I would disagree. I think it's a health problem as well. A quarter of people have been in touch with ourselves, have been in touch with specialist mental health services. Half have been in touch with emergency department services in the year before suicide. And 70 to 80% of people have been in touch with their general practitioners. So there's a specific role, I think, for health services when we think about preventing suicide.
And you've touched on it just now, but I guess what is the distinction that people mean when they say or when you think about saying it's a societal problem versus a health problem, or it's a public health problem versus a health problem? What does that speak to?
I think in some ways, you can understand it. If people are researching or working in a particular area, you tend to think that's perhaps the preeminent area. And certainly, I work in mental health services, but I recognise the importance of public health approaches. But you have to, I think, understand both bits of it. So if we're thinking about suicide prevention, things like, it's sometimes not a comfortable thing to talk about, but public health approaches, things like preventing access to lethal means of suicide. It's a really important public health measure. And people say, well, hang on, how does that work? Surely, people just substitute, they choose another method of it, but it doesn't happen. In probably about a third of cases, people might substitute another method, but what happens is often that final decision to want to tragically kind of end your life comes suddenly. So the idea is, if you prevent access to a lethal means of suicide, you give time for those suicidal thoughts to subside, and there's excellent evidence for that. So there's brilliant evidence for that kind of public health approach. But at the same time, all of us have seen the person who's acutely suicidal, who's in extreme kind of distress, and who we need to intervene with kind of clinically. So you can't think of it as one thing or the other, and that's one of if you think if I'm thinking about one of the reasons my job remains interesting as well as important every single day, it is because of that kind of multifactorial nature. You have to think about the societal, you have to think about the individual and clinical.
Can you talk about some of the factors that are there in terms of either increasing people's risk of suicide, in terms of the causes, if we can talk about causes for people dying by suicide?
Yeah, no, I think we can talk about causes, but I think the first thing to understand is it's complex. What we're talking about here are self-harm and suicide, which are behaviours which are often the end point of lots of different things happening and lots of complexity. So the complexity is certainly one thing. And the other thing is the deeply kind of individual nature of this. So we've talked a little bit about this already. So, when those of you listeners who work clinically will know that it's never the same in any two people. The circumstances are deeply kind of individual. But we can talk about things that increase likelihood of suicide. Starting right at the beginning. So it's things you're perhaps born with. So genetic factors. We know there's a genetic element to suicidal behaviour that's actually independent of just depression. So it's not just people becoming kind of low in mood and then dying by suicide. This is a genetic susceptibility that's kind of independent of that. So it's the things that you're born with can sometimes increase risk. We know suicide runs in families. If you take a life course perspective, it's things that happen to you early on. So early childhood adversity, kind of abuse, material deprivation. I mean, the deprivation story is very, very, very interesting from a research point of view. So a really interesting study that one of my colleagues did, which showed that people who grew up in deprived circumstances, even if they were upwardly socially mobile, still had a higher risk of self-harm than people that had been in more affluent circumstances throughout. So it's this idea of early childhood factors, but they kind of leave a legacy. Things that happen to you during kind of adult life, so things like kind of life events, things like psychiatric disorder. You know, if I'm thinking about some of the most important risk factors for suicide, you know, we're thinking about the types of things that many of us deal with every day. So depression. Some of the older studies suggest that 90% of people who die by suicide have some evidence of significant psychological distress or mental disorder at the time they die, with depression being the most common. Drugs and alcohol also, important kind of clinical factors. Psychological characteristics, so the way people think, can often increase risk of suicide. So we're not just talking about hopelessness, things like perfectionism and other traits. And then those societal factors we've also mentioned. So things like, the economy is the big one, but people also talk about social fragmentation. Durkheim, the great kind of French sociologist we all learn about in training, it talks about fragmented societies and how they can that can sometimes impact on mental health and suicide. So complexity in terms of causes, and the fact that no two individuals are the same, I think is the important thing there.
I mean, something that my friends often ask me, and I think you've pointed to, is it always a result of mental illness?
It's a really interesting question. So, some of the older studies say, 9 out of 10 people have evidence of mental disorder. That, from a research point of view, how did researchers come up with that? Well, they studied people who had, sadly lost their lives, and they looked back in time through clinical records, got kind of family testimonies, and kind of pieced together things retrospectively. So that 90% figure is probably a bit high. Is it an important factor in suicide deaths? I think yes. Is it a factor that's present in everyone? I'd say no. But it kind of, we get into all kinds of arguments about what you then mean by mental illness, what you then mean by psychiatric disorder. What I will say is, suicidal behaviour, both self-harm and suicide, is almost always the result of kind of intolerable distress. So the distress is always there, and how you want to label it or classify it is kind of up to you. But if we're talking about potentially remediable factor, whether you label that distress or psychiatric disorder, it's present in a fair number of people. I'd say the majority.
And I'm really interested in some of the societal factors, and I think in part because a lot of the conversation at the moment is around what the impact of COVID has been. I think there's some controversy, or I don't know if controversy is quite the right word, but there's disagreement around how much things changed from COVID, both for adults but also for young people. I wonder if maybe we talk about COVID, but then we can talk about.
Yeah, I mean, it's really it's fascinating, and one of the things I've done recently is just looked at the talks I gave through the different phases of the COVID pandemic, because suicide was a worry right from the very beginning, and the worry was, people will remember the worry was, well, the mitigation measures that we're putting into place, the lockdowns, the other things, might be worse for health than the effects of the pandemic themselves. And so there's one headline from a paper that I won't mention that suggested that suicide deaths would be would be greater than the number of deaths from the virus because of the things we were doing. And in fact, that was absolutely not the case. Many of us right at the beginning thought that we needed to be cautious about this kind of speculation. But you're right, it was, if you like, very very important, the pandemic and what happened to suicide rates in terms of studying some of those societal factors. So if you think about it right at the beginning, people were saying, all this distress, all this worry, all this mental, the mental anguish of all this is going to push up suicide rates. There's no doubt about it. The suicide rates are going to go up, and we got that quite a lot. But others of us were pointing to, periods of societal stress in the past. So things like world wars, things like some previous kind of, society-wide kind of pressures where actually there was this social cohesion effect and societies kind of pulled together. So it wasn't by any means kind of clear cut before the pandemic. And in fact, then what we found for suicide, and the best, there were, one of the problems actually during the pandemic was real-time data for suicide. So one of the problems with suicide statistics is there's obviously there's often a bit of a delay because sudden unexplained deaths need to be investigated in this country by the coroner, and that kind of introduces a bit of a kind of lag with the statistics. So there's a move towards real-time data. And both in the UK and in a really excellent study that kind of listeners can look up by my colleague Jane Purkis in Australia, showed that in 21 countries, basically suicide rates stayed the same, or actually in many cases, I think about 14 of those countries went down in the early part of the pandemic. So really kind of important data. And then a later study showing that, a less clear reduction, but no evidence of an increase. And I think that's really important. What people often ask me, what was that about? And the social cohesion effect might be part of the story, but it's much more complicated than that, I think. For me, part of it, certainly in that early phase, was increased supervision. So lots of people kind of living together, less social isolation, more supervision in terms of access to things like methods. The mitigation measures that people put in place. So many governments had economic mitigation to guard against the worst economic side effects of lockdowns and other things, and I think that might well have had an effect too. And the other thing people talked about was the fact that actually there were differential effects, and for some people, that withdrawal, that slowing down of stressful work lives, stressful school lives, was actually kind of beneficial. So really mixed effects. So, not a positive story in some ways. Meant, people are still dying, but actually, in terms of what we were worried about before the pandemic, quite in some ways reassuring. The slight the group I think that slightly buck that trend are young people, and that's a bit of a worry. In that, a systematic review we did of self-harm found that there might have been a suspicion of kind of self-harm rates slightly going up in some of the younger groups. Certainly, the evidence on distress and mental disorder in that younger age group seems to suggest that they shouldered a disproportionate impact. And in a recent paper is really interesting. I'm just co-author on it, looking at self-harm and eating disorders actually from a perspective of primary care. So a big primary care database called the CPRD, looking at what happened to self-harm rates. What you see fairly consistently is a decrease in hospital and emergency department and primary care presentations for self-harm in the early part of the pandemic. That kind of mirrors the reduced help seeking across healthcare though. But this recent paper by Alex Trafford and Pearl Mock and colleagues showed that after that dip, there's actually been a further increase in self-harm presentations to primary care for young people. What's more, though, and it's kind of slightly kind of buried in a supplemental file in the paper. I think one of the most interesting graphs in the paper. It's always difficult describing graphs, isn't it, on podcasts and things? But I'll have a go. And basically, the pattern there is a long-term increase in self-harm rates in young people, especially girls. a kind of, fairly steady increase over the past, few years that um, uh, has a rapidly, an even higher upward trajectory in the post-COVID period. So I think we do need to be thinking about this kind of, you know, in the long run, and often, people talking about, COVID and post-COVID now, and for me, a lot of this isn't about COVID now. So the upward trajectory after the COVID pandemic isn't just all about COVID. In fact, it's about other stuff. It's about the stuff that's going on at the moment. It's about wars in Europe and elsewhere. That impacted economically on the lives of, on the everyday lives of people. Cost of living crisis for young people. It's the educational pressures. It's some of the existential threats. It's climate change, probably. It's other things. So I mean, we don't know any of this for certain, but these are some of the kind of pressures that young people are coping with, which I think are reflected in increasing rates of self-harm. We've also got increasing rates of suicide in young people in many Western countries. Last couple of years, that may have levelled off in England and Wales, but certainly increasing rates of suicide. So we've got increasing rates of suicide and self-harm in young people. The other societal pressure that I've kind of not mentioned, and you and your listeners can make your own mind up about why I haven't mentioned it so far, is social media. So social media, the lives of young people, does it cause self-harm? Does it cause suicide? It's really tricky. Many of your listeners will be familiar with the media reports. For some young people, they've accessed deeply harmful content, and yes, it's been harmful for some young people. For other young people, the social media contact has been helpful. There's clearly some things online, things about facilitating self-harm, things about methods of self-harm and other things that absolutely there's a role for regulation. But the other thing is, social media is part of our lives, part of our existences. We need to think about how young people manage it, how parents manage it. So it's a really tricky thing. But there's definitely a role, I think, for regulation, and the new social media bill kind of reflects that. It criminalises some aspects quite rightly. If people are facilitating self-harm or suicide, and also puts in place some provisions for regulating content.
You've said a couple of times that there have been rises noticed in Western countries, or that, and then things have maybe leveled out. Is that in comparison to other countries, or does that comparison exist?
Yeah, I mean that's a good point. One of the big gaps is data, actually. So although overall we know that 3/4 of the world's deaths occur in low and middle income countries, the number of proper surveillance systems in the global south are minimal. So definitive data on trends is kind of difficult to get. So you couldn't say, well, it's risen in Western countries and fallen in low and middle income countries. Those data comparisons don't exist. I mean, one thing to say about low and middle income countries, and if you like the age breakdown, is there's a disproportionate burden on young people in those countries. And again, I'm going to describe a graph on a podcast. So if you think about an age distribution of suicide in the UK, what we have is a peak in midlife. Rates increase towards older in older adults a little bit as well. But if you like, the peak age is people in midlife, especially males in midlife. But the pattern is very different in low and middle income countries. It's primarily young people, so you get a young people's peak in low and middle income countries in there, and many of the pressures that young people face, globally are similar, specifically kind of some of the economic ones, but it is a different pattern.
A hard question, but why? Why that age difference?
Yeah. So I mean that's really challenging and interesting question. So, I mean, there's a couple of things really. I mean, first, if we just think about why the age distribution is as it is in the UK. So, why have we got a peak in midlife? And that's fascinating because if I'd been talking to you 20 or 30 years ago, I wouldn't be talking primarily about men and women in midlife. I'd be talking about young men in their 20s. So if you think about it, 20 or 30 years ago, I'm talking about young men in their 20s with the highest risk. Now I'm talking about men in midlife with their highest risk. You can see where I'm getting at here. This is, is it the same group of men who have simply grown older in epidemiological terms? Is it a cohort effect? And primarily, and partly we think it possibly is a cohort effect. So that group of men have grown older. The question is what scarred that group of young men back in the 80s and 90s. And again, one of the theories is kind of economic factors. And there's a very good paper. There's lots of papers out there which I wish I'd published myself. And there's a paper by Scottish colleagues where they actually blame Margaret Thatcher, not Margaret Thatcher specifically, but the effect of her kind of economic policies on that generation of young men. So we've got this group of men in midlife, other theories for why that group of men, why that group are particularly high risk, theories around kind of masculinity, theories around help seeking, and theories around kind of, societal stress on that group, both economic stress, drugs and alcohol and other things. Help seeking is really interesting because, people say, well, the higher rate in middle-aged men is because they don't seek help. Is that right, Nav? And for a long while, you say, yeah, we think that's a viable theory. One of the great things about doing research is you get to prove yourself wrong. So a couple of years ago, we did a study of suicide in middle-aged men, and it was an unselected sample. So it's a random sample of people from the general population. So it wasn't just patients. And we looked at their service contact. And what we found was that 90% of these middle-aged men who had died by suicide had some kind of service contact. So, primarily primary care, but also mental health services, emergency departments, social services, also kind of criminal justice. But this idea that men don't seek help is partly true for a proportion of men. But, I think partly the narrative needs to change. It's about making services fit for purpose for when men do attend. So that's the age distribution in the UK. I mean, the other thing we haven't really talked about, which is, really important, which is the gender distribution. So it's 3 times as many men die by suicide as women in this country. And, I live with this statistic, a lot. I kind of present it a lot, but that's astonishing. Every time I say it, it's kind of astonishing. And what on earth is that about? We've talked about help seeking, we've talked about some of the risk factors, and one of the other reasons, again, slightly uncomfortable to talk about is but it could be to do with methods. So when men hurt themselves, they do so using more dangerous methods that are more likely to result in death. So that's one of the part of the story. The other part of the story, psychological traits. So men, people have talked about men being more impulsive than women. Whether you believe that or not. There are some of these psychological traits that might make suicide more common in men, but we haven't really kind of got to the bottom of that. But 3 times as many men as women. In low middle income countries, the gender ratio in some parts is a bit more even. In fact, in areas of rural China and rural India, that's reversed. And again, what's that about? That again is probably about access to lethal methods. So pesticide poisoning is quite common in those settings, and that's probably part of the reason. And probably part of the reason for the peak in young people as well. It's about accessibility of methods, possibly. So yeah, it's these things, and these things do vary over time. So age and gender patterns do vary over time. Older people are another group who, I mean, in one of the World Health Organization reports, you can read that, in general, suicide risks, increases in a linear fashion with age, and depending on how they cut the cake, that's true. So older people, many of you listeners working in older people's mental health services will know that suicide and self-harm are big problems in older age groups as well. What's that about? That's about risk factors like physical illness, bereavement, social isolation. So there's this idea that suicide and self-harm occur across the age span, and actually the interventions will be different depending on where across the lifespan that these things happen.
And it's like I planted that, because let's talk about interventions. I think, I read one of your papers where you sort of showed the huge decrease in suicides that can be done by implementing changes in the way that services are run. So kind of at a healthcare level. You've touched on some of the guidelines that exist in the UK on a societal public health level as well. But yeah, I wonder if I can ask you to talk about different level of intervention.
Yeah, I mean, let's be a bit non-linear about this, and we've not really talked a lot about guidelines so far, and I'm a big fan of guidelines. In fact, some of my colleagues tease me and say I'm a guideline junkie because I've been involved in so many nice guidelines over the years. So primarily the self-harm guidelines. I chaired the earlier one. I was the expert advisor on the one that came out last year, but also kind of chairing depression guidelines and other things. And I'm a big fan of guidelines. Sometimes people say, "Oh, well, guidelines just sit on people's shelves now, if no one reads them." But I think people do. There's some evidence we can show for change in response to guidelines. But I'm a fan of guidelines, especially in contrast to the early part of my career where I didn't know or what this thing called evidence-based medicine was, or was suspicious of it in any case. These are the NICE guidelines, the National Institute of Health and Care Excellence guidelines. World leading guidelines are evidence-based, so we look at randomized controlled trial evidence, but they're also consensus-based. So we've got a bunch of us sat around a table, either in reality or these days more commonly virtually, and decide on consensus-based care where the evidence doesn't exist. So I think in terms of what makes a difference for suicide and self-harm, I think those clinical guidance, that evidence-based care that we then implement. I think one of the things we have been a little bit weak on in the past is focusing on implementing the guidelines as well as developing them, but we've done a bit of that. So there was a sequin. So those of people working in the English mental health service know about these. These essentially targets. There was a sequin a couple of years ago for self-harm and improving assessments for self-harm, and we could show that made a difference. So guidelines, I think, are really helpful, and I'd encourage people listening to kind of get involved with them, because they're fun to get involved with, and then you're affecting the clinical care of everyone who presents to services, not just the patient in front of you. So as a clinician, I think they're really great things to be involved in. In terms of what else kind of, if you like, helps, you mentioned the kind of service changes, but before we get to those, just thinking about what helps in at the point of a kind of individual. And I often like to talk about things that help, and maybe things that don't help so much. So at an individual level, so someone who's presented to the emergency department after having hurt themselves, what helps? The first thing that helps, which I think people find slightly surprising, is just the assessment. So just making sure you as a mental health colleague or someone else is doing what we call a full psychosocial assessment. So a full assessment of psychological needs, social circumstances, and just that full assessment. Some of our observational data, so it's not randomized evidence, but some of our observational data suggest just doing that assessment properly reduces the risk of repeat self-harm by about 40%. And that's partly when we ask patients, when we ask service users what's that about, that's partly the feeling of being listened to, but it's also partly about people being plugged into appropriate care. So just often busy clinicians in emergency departments will be saying, oh, it's really difficult, we're really busy, and we're seeing people, and there's lots of people coming in with self-harm, and I wonder whether we're doing any good. And one of the really positive messages I like to give people is actually, you are doing some good, even though sometimes you might feel like the service pressures, etc. On average, you're reducing the risk of repetition by 40% every time you see them. So one of the things we have pushed is making sure more people get seen. So these people presenting to services, the surprising fact is only about half of people were getting a kind of psychosocial assessment. So we've worked hard at pushing up that level. So that's the first simple thing. The other simple thing is plugging people into aftercare. So we know from the NICE guidelines and other things that psychological interventions, CBT and related interventions, they're effective for people after self-harm. So again, reduce the risk of repetition by maybe up to 50%. So reduce the risk of repetition up by about 50%. Do we provide them routinely in the English National Health Service? No, we don't. In fact, up until recently, nowhere provided these things, provided talking treatments routinely. So, again, there's something there that on an individual level you can do. The other thing on an individual level, I think that we shouldn't do, and I've talked a lot about this over the years. In fact, my first paper on this was in 1998, I think, against a high risk strategy for suicide prevention. So the idea that you can simply pick people who are high risk, intervene with those people, and reduce suicide overall is a very seductive idea in many ways. It's the way we work in mental health, the way we work in psychiatry, because we've got to focus our resources, don't we? The problem with that is kind of many of your listeners will know, it's the predictive value of these assessments, our risk assessments. Even when we're using tools, the predictive values of those, the predictive value is very low, because even if you've got 100 people who present to emergency departments, thankfully not many of them, even though the risk is increased, not many of them actually go on to die by suicide in the following year. And so picking that person is really, really difficult. In fact, it's impossible. And all the many people you rate as low and medium risk, some of those people die by suicide. So it's this positive predictive value. Positive predictive value we often talk about is 5%. So what does that mean? That means if in an emergency department 100 people are rated as at high risk, only 5 of them will be at high risk. In other words, you're wrong 95% of the time. But the bigger problem is all the people who you're rated at low risk and moderate risk. So the big problem with the risk assessment thing, people often kind of ask me, is the idea of exclusion. But that's not to say we should have the same treatment for everyone. This isn't about the same treatment for everyone. What it is, though, for me, is a something for everyone approach. So it's about tailoring treatment to a person's needs. So, a middle-aged man with a drug and alcohol problem who lives alone, who's made a medically serious, self-harm, had a medically serious episode of self-harm, is different from the younger person who might attend with their parents, who's, self-harmed in response to distress as a means of managing that distress, and is plugged into services both at school and in the community. So the needs are different. It's not about the same for everyone, but it is about, I think, a something for everyone approach. So yes to psychosocial assessments, psychological interventions, moving away, I think, from risk assessments on an individual level. On a service level, I think these are really powerful.
Before we go to the service level, could I ask you something else about the individual level?
Yeah, of course.
And I guess this is again a question coming a bit from things that people have said around me, but I guess it's probably now a cliche that you can't make someone more suicidal or self-harm more by asking them about them. I think probably that's entered public consciousness fairly well. But I guess in my experience, there probably are things that people say that can make someone feel worse, particularly the types of things that patients have said to me is, how could you do this? Or sort of, you've got so much good in your life. How could you do this to people that love you? I know you've done qualitative studies. I mean, do you have a sense for what patients say beyond my individual experience about the kinds of things that aren't helpful, be it from friends, family, or professionals.
Absolutely, and there's a large and quite depressing literature on this, and people, service users, patients, their experience of services, and I mean, largely it's not. I mean, the content is important, and there's some examples of dreadful, blaming, unhelpful content out there. And I wouldn't want listeners to think that's invariable. There's some examples of excellent care out there, but it isn't just the content. And this goes back to the idea of psychosocial assessment. It's the how rather than just the what that's discussed. So we often talk about kind of compassionate, empathic care, the kind of that the basic kind of active listening that we all should practice all the time. Those of us who are mental health professionals, it's that how. So that how is really important, and actually even more important than the what. But absolutely there are those kind of blaming attitudes, those being kind of overly kind of challenging. That there's not generally a kind of place for that kind of thing. It's about the active listening that when we talk to patients and service users, they find most helpful. Yeah, so sorry, that was a very helpful kind of interjection there, thinking about the individuals. The service level stuff you've mentioned our research, and that's really interesting. It's observational data, so you have to kind of bear that in mind. It's again not a randomized trial, but what we do as part of the National Confidential Inquiry, and I lead the suicide work. Lewis Appleby kind of directs the whole thing. I lead the suicide work. Is we over the years, we've made various suggestions for how services might improve, be it inpatient care, post discharge care. So the studies we've done looking at service changes in suicide, I think, have been really interesting. So I lead the suicide work of the National Confidential Inquiry, and what we were able to do, what we've actually done over the years is suggest things that might improve safety for services. And what we were able to do in a study a few years ago is look at the impact of those service changes, if you like. So what we did was for every mental health service in England and Wales, we lined up the date of implementation of these various service changes, and we looked at suicide rates before and after. And what we found is for the majority of those service changes, things like improving inpatient care, post-discharge care, drug and alcohol services, we found reduction in suicide rate after they'd been implemented. But for three changes, and that was the provision of 24-hour crisis care, having a policy for people with mental illness as well as drug and alcohol misuse, so comorbidity, and involving families in post-incident reviews. So introducing those changes had particularly large effects. So the equivalent of 200 to 300 fewer deaths per year after those changes had been implemented. And we didn't see those same falls in trusts in mental health services which hadn't implemented the changes. So, some evidence that certain aspects of care, the family involvement might be a marker of a learning organisation. You've got the drug and alcohol, you've got the acute crisis care. Those things have an effect. But I think the story is even more interesting than that. So the other thing to take into account, of course, is the organisational factors. We're acutely aware of that at the moment. Given the state of health services, given the pressures that mental health services are under. But the context is really important. So the other thing I thought about is well, what about the organisational factors? And one organisational factor in particular came out, and that was staff turnover. So what we found was organisations, trusts that had a greater turnover of staff, mostly nursing staff, had higher suicide rates. So it wasn't a strong association, but the association was there. It was statistically significant. That's interesting. Again, it's an association, it's not causation. But what was fascinating is when we, if you like, superimpose the organisational factors on the individual factors. And what we found was that in organisations which had a stable workforce, so had a low staff turnover, those service changes, so things like, introducing 24-hour crisis care, had more of an impact. And if you think about it, that makes absolute sense, doesn't it? That you can, change a service all you like, but the context of that service, staff turnover, the stability of the workforce, actually, I would argue the mental well-being of the workforce as well. Those are important contextual factors. So you can tinker with, service changes all you like, but you're kind of wasting your time unless you're paying attention to those organisational factors. So I think those, if you like, service level factors are really important. And in a way, it's an example of, if you like, the last bit. So the first bit is individual, the second bit is service level, but the last bit, I think, is societal and system-based approaches to suicide prevention. So when I talk about system-based approaches, that's doing lots of different things at once. And, that I think, again, can have, if you like, synergistic effects. So thinking about doing lots of things together can have more effects than just doing one thing. And if you like, our work, the work I've just described in terms of services is a very nice infographic on our website, 10 ways to mental health safety that many people be familiar with. And that's an example of, like, if you like, a system-based approach within a system, which is mental health services. But you've also got system-based approaches, I think, that do some of that societal stuff. So it's, method availability. It's things like media reporting as well. So that's another public health measure. So we know that sensationalist or bad media reporting, when people are talking a lot about methods or sensationalizing accounts, can lead to increase in suicidal behavior. It's well demonstrated from a 18th century novel by Goethe, The Sorrows of Young Werther, where basically a young man who's wronged in love takes his life. And there were a series of imitative suicides across Europe. So back historically, from The Sorrows of Young Werther right through to a Netflix series, 13 Reasons Why, which again researchers have demonstrated led to an increase in suicidal behavior. So those public health measures, the economic, the effects of economic policy. So, one of my colleagues in Oxford has coined the very pithy and memorable soundbite, which is about recessions and austerity. So economic recessions hurt, but austerity kills. So it's if you like, the policy response to economic turmoil that determines what the health impacts are. And there's some evidence that in societies which increase societal and health spending at a time of economic stress, if you like, mitigate against any increase in suicide risk, whereas unprotected societies, the suicide risk increases. So thinking about both the mental health services within that system-based approach.
What do you think about the phrase zero suicide, or about the aim of zero suicide?
It's such an interesting question, and so there are such different views as well. So where I currently do my NHS work, my NHS sessions, that's Mersey Care. That's a zero suicide trust, and they're leaders in that space. But I'm quite open. I have some misgivings about the term zero, and we've had conversations with the zero suicide leaders in the States and elsewhere, and so I have some difficulties sometimes with the prospect of zero, because colleagues, brilliant colleagues, wonderful colleagues doing excellent work in the area will tell you zero is not a target. They will tell you it's an aspiration. But within the context of our health services, sometimes really difficult for it not kind of slipping into a target. And I know staff also sometimes tell me, the zero suicide stuff we're really uncomfortable with, because then if a death does occur, in a organization with maybe a more blaming culture, we kind of get blamed. So and service users and families have also told me they're uncomfortable with it at times, because there's a notion that if a suicide death tragically does occur, that's somehow a failure of the family, etc. So, you know, the zero, I think, is I personally have some misgivings about, but other colleagues will tell me, well, if zero isn't the right number now, then what is? For me, it's not about. I mean, I'd slightly, you know, sometimes people say, well, every suicide is preventable. I slightly reframe that in that no suicide death is inevitable. So, you know, there are things we can do. We must do the best we can, and I think, in a way, that's what zero suicide's about. It's about doing the best we can for every single person that comes through services, and no one would argue with that aspiration. And certainly, some of the things when you look at what zero suicides involved in practice, some of the things that we've talked about on this podcast, you know, it's things like method availability, it's things like improving services, protocol based care, guidelines. Yeah, we're talking about the same things, and we're talking about the same end point, which is about you know, providing the safest possible care. The other thing, though, which is, you know, a bit, in some ways, a bit uncomfortable, because I don't like the, you know, I'm not particularly comfortable with the zero. Um, but the other thing that it did do was it did make politicians sit up and listen. So it did have an important galvanizing effect, I think, because people like me have been talking about suicide prevention for 20, 25 years, kind of get listened to. What gets listened to most, I think, are people with lived experience, carers and relatives. When you get people like that up in front of policymakers, things change. And I think that's been great. And so, you know, acknowledging their contribution in all this, I think, is very, very important. But I think the zero suicide movement have a role to play as well. They'll galvanise some of that thinking. It was an easy message to understand, although, you know, being very careful not to get the message misconstrued. And, you know, I think played a role in suicide prevention having the priority that it does today. So, you know, we've had a new nice guideline for self-harm come out in 2022. You know, just a couple of months ago, we've had the new suicide prevention strategy for England come out, and that's good. I mean, it's not just a strategy; there are concrete kind of measures in there. One of the most exciting, I think, is it from a policy point of view. So it's making sure that every policy, you know, if you like, is viewed through a mental health kind of lens. So every new policy is looked at across government in terms of kind of potential mental health impact and ultimately kind of suicide impact. So some of that stuff I think is in the strategy. Encourage people to have a look at it, and that wouldn't have happened without the efforts of, you know, service users and carers and you know, the efforts of everyone. And I think that's a really important message for suicide self harm prevention. You know, everyone's got a role. You know, I think clinicians do have a role, definitely. You know, that's what I kind of do. But everyone has a role. Service users and carers, policymakers, the third sector, you know, police, you know, everyone's got kind of got a role in this.
And I think we've touched on it, but I'm wondering if there's anything else in the new self-harm guidelines from last year that, because I guess my reading of them is that they represented a change again in that how things are done and in the approach that is taken with people coming to health services with self-harm. Is there anything else that changed from the previous guideline that would be important for us to talk?
So I'm often asked that. I'm often asked what's new in the self-harm guideline. The first thing is it's actually a combination of what we had before. We had a kind of slightly awkward combination of a short-term self-harm guideline and a longer-term self-harm guideline. And in one or two places, they didn't quite match up. So the first really important change is this is the new self-harm guideline. It's self-harm short and long-term. It doesn't cover physical management. You know, we decided that was something quite different. So it's not a toxicology guideline. It's very much a mental health and social care, primary care type guidelines. So that was the first important change. The second change, I think, in the guideline is really trying to get across the idea that self-harm can present in a wide variety of different settings. So present in workplaces, present in schools, present in primary care, present in the community, and thinking about what the role of people were in those spaces as well. So this idea about, self-harm being everyone's business, that was one of the things we did when we kind of launched the guideline. In terms of, many of your listeners I know will be more interested in the mental health aspects. There haven't been huge changes from that point of view, and the key things for me there are things we've already talked about. So the provision of psychosocial assessment for everyone, and the ready availability of psychological treatments, and commissioners hearing that as well, because those things are cost effective. So by introducing talking therapies, you're actually going to save money, because people are less likely to repeat self-harm coming back. The other thing I think, that's changed a bit from the last guideline is safety plans, and many of people listening will know about safety plans, this idea that you're thinking about, well, sitting down with a service user, thinking about what happens, should the distress occur again, who will people contact, what's their plan of action, what are the kind of warning signs, and they're good. I mean, the evidence base isn't quite as strong as some people think, in terms of the randomized control trial evidence base isn't quite as strong as people might think. Do I think they're a good idea? Yes, I do think safety plans are a good idea, but again, it's the how rather than the what. Again, I'm hearing of instances where the safety plan becomes a kind of formulaic response rather than a collaborative intervention, which it must be. So safety plans are something that I think have more prominence in this guideline. And the other thing I think is related to that is this idea of after risk. So we're saying don't rely on just risk assessment or risk assessment tools, but we do talk about risk formulation. So this idea that you bring together all the different bits of people's circumstances and their current history in order to kind of formulate a kind of needs based plan, which you act on. So those are important things for people to, I think, look at. And it's tricky, isn't it? I know the problem. The guidelines are vast. They're kind of slightly fragmented, but I would encourage people to have a good look at those, because there's lots of good stuff in them.
So let me ask my last, maybe tricky question, particularly in reference to the self-harm guidelines, but maybe more generally. Is it doable in the UK, in the NHS, as it is?
I think this issue of how we implement high quality services, how we implement the best care in services that are under such pressure is if you like, one of the big questions of our time. Is it resources? Well, resources are possibly part of the answer, but they aren't by any means all of the answer. It's about how we're going to work. Some people are talking about AI saving us all, and I don't think that's going to happen. I think certainly the idea of AI machine learning being used to predict suicide and improve assessments, that's overstated, I think. But this idea of how we provide the best care in pressured systems, I think, is a live one. But it's a huge one. It's in mental health services, just looking at staff vacancies, that's one of the live issues. So yes, it is doable. It's going to be very challenging over the next few years, I think, but actually implementing these guidelines, implementing best practice, I think will make systems work better, and therefore will provide kind of safer care. So yeah, I think it is doable, and I think going back to one of the things we've talked about before, that even when it's really pressured, my mental health colleagues on the front line, realizing what a good job they do, just by talking to people, they're reducing the risk of repetition by 40%. I think it's really, really important, but it's going to be challenging.
Nav, thank you so much. Thank you for sharing your time and your expertise. If people want to follow your work or read more about the studies that you're running, where can we point them to?
So the University of Manchester website, and I'm not on Twitter, but NKISH, the National Confidential Inquiry into Suicide and Safety on Mental Health Services, are, and there's lots of resources on the NKISH website as well. But we're on email and other ways of other ways of getting hold of us as well. So always happy to talk to people.
Thank you so much. Thank you for coming to speak to us, and it's been wonderful to hear from you.
That's great, Anya. It's been a really interesting chat, and thanks for having me on.
Absolute pleasure. I really hope that you found this episode valuable and informative. We've included a link in the show notes to some resources where you can access more information, but also helplines and places where you can access support if you want these for yourself or to share with somebody else. As always, we love to hear feedback from you, so feel free to drop us an email or get in touch with us on social media. If there's someone who you think would enjoy the podcast, do share it with them, or drop us a rating on Apple Podcasts or on Spotify, because this really helps other people to find us. Thanks so much.